Bowel obstruction is a term that can refer to simple constipation or more serious conditions where the bowel is blocked and medical or surgical intervention is required to relieve the blockage. So this is a common presentation in the ER. Somebody often will present with abdominal pain, nausea and vomiting, and inevitably the absence of flatulence or bowel movement, obviously, since the bowel is blocked. So there are chronic conditions where people haven't gone to the bathroom in days, and they'll come to the emergency room complaining of not being able to go to the bathroom. Or there are the more acute conditions that are usually associated with more pain, and these people may have only not been able to go to the bathroom for a day, but they're in a lot of pain and they know that they're not able to go to the bathroom. So there's ileus, which is usually referring to a problem with motility, and then there's a true obstruction where there's something blocking it, whether it be intraluminal blockage, such as a fecalith or some kind of a foreign body, or a growth within the lumen, or sometimes you can get blockage from outside of the lumen, either by a adhesion from a prior surgery, or often from some kind of a neoplasm. And it's important to differentiate whether this is happening in the small bowel versus the large bowel, both for differential diagnosis and for treatment. So in the small bowel, the most common causes of blockage are either mechanical or functional blockages, which we kind of mentioned before. The mechanical blockages include adhesions, when scar tissue pulls the bowel or puts a kink in the bowel. Incarcerated hernias, where a piece of the bowel has gone through a hernia hole and has either twisted or been kinked, and it doesn't allow anything to pass through the bowel. And then cancers. And appendicitis can also cause bowel blockage as well, just from the inflammation. And appendicitis also can cause bowel contracture, which leads us to functional problems like paralytic ileus, which can be associated with some kind of infection or inflammation, or it also could be caused by drugs. The most common cause of paralytic ileus would be pain medications and other drugs that cause the small bowel to lose muscle tone. Inflammatory bowel disease also can cause a functional bowel blockage. In the large bowel, there's volvulus, where you get a twisting of the bowel. This is going to be more common in older people. Then there's diverticulitis, which could be a true diverticulum, like a Meckel's diverticulum, or it could be from diverticulosis. And again, colorectal cancer is probably the most frightening, the most important thing on your differential diagnosis to rule out. And then you can also get a colonic ileus, also known as Ogilvie syndrome. Here is a picture of the bowel. Here is a list of things that we want to take into consideration on an exam. So bowel distension is a common cause of, or a common characteristic of acute bowel obstruction. Visible hernias are something we need to look out for, to add that into the differential diagnosis. If you can see any type of a mass sticking out, of course, that's something that we want to take into consideration. And then we look for scars, and Of course, you can imagine that we're looking for scars because that could be a sign that there are adhesions underneath that may be causing our obstruction. On the exam, we also auscultate to make sure there are no bowel sounds. If there are bowel sounds, normal bowel sounds, then you may want to look into another diagnosis besides bowel obstruction, but a lot of times you will have some high-pitched sounds in incomplete bowel obstruction, and that can also help you to localize the obstruction. Percussion can tell us if we have a tympanic bowel or tympanic abdomen, which lead us to the idea that there is fluid in the peritoneal cavity, the peritoneal cavity, and can help us start to think about things like perforation, which is also a possibility with some of these causes of bowel obstruction. Palpate the bowel to see if you can find any masses, neoplasms, or inflamed spots. And we also do a rectal exam. Now, for most cases of bowel obstruction, it's going to be higher up than you can reach with a rectal exam, but there are cases where you'll have a rectal mass, which could be causing the bowel obstruction, and it's always just a good idea to rule that out. So we also want to send some lab tests out. You do CBC, including white blood cells, hemoglobin, hematocrit, and platelets. This can tip us off to the idea of infection or inflammation with the white blood cell count. Hemoglobin and hematocrit can give us an idea if we have some bleeding within the intestines. And platelets can also make us think about bleeding and other comorbid conditions. Electrolytes can help us know if we are bleeding. That can be a sign of or a reason that we have changes in electrolyte levels. A hypochloremic, hypokalemic alkalosis is something that we're often going to see with these bowel obstruction cases, because most of these people are throwing up, or a lot of these people are throwing up. And when you're throwing up, of course, you throw up a lot of acid. So you get a hypochloremic, hypokalemic alkalosis. The hypokalemia is a metabolic reaction to the alkalotic state, where the kidneys start getting rid of potassium in order to keep hydrogen ions. You also want to do a BUN creatinine, urinalysis, liver function tests, amylase and lipase. These mostly can help us rule out other causes of bowel problems or other causes of abdominal pain that might be on the differential diagnosis list. Then you want to take them in and get some pictures taken. So you do proximal bowel dilation, or on plain film you look for proximal bowel dilation, you look for air fluid levels. In a bowel obstruction, a true bowel obstruction, you'll often see a distal collapse. So if it's completely obstructed, then anything after the obstruction will be empty and collapse usually. Small bowel dilation with air in the large bowel is something you want to look for. And then a string of beads sign, which is associated with the collapse that we were talking about. We also want to take a CT scan. The CT is most sensitive, and it can help us to show the cause, and can help us to better figure out what our treatment's going to be. So on the CT, you'll be able to see if we've got adhesions that are causing problems. I don't know what I meant by writing transition of bowel caliber. Oh, I think that's talking about the distal collapse that we mentioned. And feces sign. You can actually see feces in the CT. On the CT, there's something that they call an apple core lesion. You can also see these with a barium swallow, but you probably don't want to be doing barium swallows if you suspect a bowel obstruction, at least a complete bowel obstruction. So this will be where you can see a narrowed spot that is constricted by a tumor which surrounds the bowel. And there's also a sign you can see on CT. It's a closed loop or a U shape due to tethering. So if you have an adhesion or something that's pulling the bowel to the side, you can see this U shape. Some of the complications that can happen with these small bowel obstructions are ischemia. If you have the bowel that is overly distended or overly inflamed, you can lose blood supply. Portal venous air is a situation that you want to worry about. You can actually get air up through the bile ducts into the liver, and so that's another sign that you can sometimes see on imaging. Perforation is a complication that you need to be aware of. That can be potentially life-threatening. And mesenteric venous air, the pressure, and I should have said it this way, under portal venous air too, but there's the pressure from the bowel obstruction can push air into the venous system, not through the bile ducts like I erroneously said on the portal venous air. And ischemic bowel, which we talked about. So what do we do to treat this? Well, of course, it's going to depend on what's causing the obstruction. The indications for non-operative treatment would be if there's fever, peritonitis, incarcerated hernia, increased white blood cell, and failed non-operative management. So these, let me just fix this here. Okay, so this is our indications for operative management. So the reasons that we would want to do an operation immediately is if we have these things that I just mentioned. If you have fever, peritonitis, incarcerated hernia, increased white blood cells, and or if we've tried to do non-operative management and we haven't been able to fix the situation. Really, the main reason you don't go in and do an operation is if you've had prior abdominal surgery and there's adhesions, you know what's going on, and so you try and manage it without surgery. These are the things we just talked about for reasons you do surgery. And so if we don't want to go in and treat this surgically, we can do an NG tube, we can stop feeding, and if necessarily give total parenteral nutrition, and just along with that fluid resuscitation, and then of course put a Foley catheter in and monitor liquid output. If we do want to do an operation, you can do both open midline incision and laparoscopic surgery. In either case, you're gonna run the bowel, which just means you're gonna follow the loops of the bowel up to down to the terminal ileum up to the ligament of Treitz. You identify the dilated bowel and the decompressed bowel. So basically, you see the area where the obstruction is by finding the spot where it's dilated, and then on the other side it's decompressed. You're going to cut down adhesions that could be causing the problem from prior surgeries, and resect necrotic bowel, get rid of anything that's dead, and then you re-anastomose it, you get it back together. So just a word on how that works. There's different types of staplers that are used for re-anastomosis. In some of these cases, if there is, for example, if there is infection, then you might not be able to re-anastomose immediately. You might have to do colostomy, either a temporary or a permanent colostomy, hopefully a temporary colostomy. But in either case, you're going to be, or most cases, you use a stapler to cut and re-anastomose the ends of the bowel. So they have different types of staplers that I think I talk about under colon surgery. There's the GIA and the TIA staplers and the end-to-end staplers. So if you want to learn more about that, you can go to the colon cancer video. In the post-operative period, IV fluid, you keep them on the NG tube. So we're not going to be giving these people food, obviously, immediately if they've got anastomosis in there. And you can remove the NG tube when the output is less than 200 cc's per shift. So basically, if you're not sucking stuff up anymore. And oral liquids after the patient passes gas. So you need to wait until they hear some gas coming through. The complications, of course, that are associated with it are abscess, leak, infection, bleeding, and then, of course, regular surgical complications like DVT and UTI from having a catheter, and pulmonary complications from anesthesia. And this stuff does happen. It's not like other surgeries where these complications are pretty low on the list. You know, infection and bleeding and leakage of the bowel all could happen on pretty much any given re-anastomosis of a bowel. So it's something to monitor for very carefully.